your prevention of falls.
Well, I was surprised to hear it's recorded, so if I'm sweating a little bit, you'll know why. But I'm just going to start off. I was in research class with Dr. Long and Dr. Ford, and also in education at UMC, and it kind of just became this monster, which actually turned out to be a really cool thing, which I decided to do specialized fall prevention training for unlicensed assistive personnel. And I think everybody here knows what a UAP is, but originally I was doing it for nurse techs and nurse aides, but when you look in the research, you don't really find those terms anymore. It's UAPs. So I went through and I'm just going to go over a few fall facts, which probably all of you already know if you know anything about falls. I mean, these are pretty much the basics. Falls are a nurse-sensitive measure, and nurses play a key role. Whoops. How do I? Previous. There we go. Falls are a nurse-sensitive measure, and nurses play a key role in patient care at the bedside, keeping patients safe. Successful fall prevention programs have only been able to reduce fall rates by 30 to 40%, which is it hurts your heart whenever you're the ones trying to prevent falls. But this is what has been pretty much the norm for everybody. When a patient is seriously injured with an inpatient fall, it can cost a hospital up to $27,000. And I've been working with our money guys at UMC to try to nail down how much falls without injury and how much falls with injury, and depending on the type of injury, what they're actually costing our hospital, and they're still working on those numbers for me. But I'm excited to hear what those numbers actually are so we can look at actual savings. The Centers for Medicaid and Medicare Services, otherwise known as CMS, declared falls as a never event in 2008. And CMS also includes falls as one of those, our favorite terms, hospital-acquired conditions that are not eligible for reimbursement. According to Quigley and White, nurses are the key players in ensuring patient safety and quality in healthcare because they're the most likely to spend the most time at the bedside. And they're in the best position to monitor and remove risks and improve patient safety outcomes. When you have really fancy PowerPoints, sometimes it can work to your disadvantage. Just a few more fall facts just to give us some background. Inpatient falls are the most commonly reported adverse event in the United States, which that alone says a lot, because how many adverse events do we have to report? Quite a few. According to a systematic review, falls are probably actually underreported, but most estimates report that falls in acute care hospitals range from about 1 to 9 per 1,000 bed days. Fall measures have been recognized as important to patient outcomes all over the country, but not all falls can be prevented, and that's the hard part. Like with CLABSIs, you know, there's a lot we can do to get down to zero, but in the end, it really, I don't know that we could ever prevent all falls because there's this thing called gravity and free will. So those two combined don't work out well with preventing falls, all falls. Falls happen with about 3 to 20% of inpatients falling at least once, and of those, 30 to 51% of those experience some sort of injury. Falls are not only a problem in the United States, they're actually a worldwide health problem that everybody all over the world is trying to prevent falls. In fact, this is just a tidbit, but my 14-year-old is in All Saints in the science fair, and his science project this year is building a biped stabilizer for elderly in their homes. So I don't know where you got this idea, but the passion is extending on falls. So yes, exactly. I was like, we should work together on this. Speaking of, the elderly are more prone to falls, and then they have more severe consequences when they do fall. I know that we could probably all speak to this as we've fallen throughout our lives, that the older we get, the harder we do fall. And in all of the classes that I taught, I asked everybody who had fallen, and I'm like, the ones who said they hadn't, I was like, you're not admitting it. I know this is the truth. Okay, who all here has fallen? Right? Really? You've never fallen in your life? Well, see, you've fallen. There you go. PD falls count too. So with the aging of the U.S. population, finding effective fall prevention strategies is more important than ever before. Training both the nurse and the nurse assistant is important because many of the activities of daily living are delegated to our nurse assistants or our UAPs. I don't want to overclick here. A patient fall is defined as an unplanned descent to the floor with or without injury to the patient. And that seems really self-explanatory. But when I was at a magnet conference and I went to a fall lecture, they showed a video of a lady who was in her patient room, and they had her on video, and she got out of the bed, she sat down on the floor, and then she laid down on the floor, and then she yelled out, "Oh, I've fallen." So that was obviously a planned descent to the floor, which was interesting. She was a psych patient, and she had some issues other than gravity and free will. But so that struck me whenever I saw that. I was like, oh, okay. On a side note, I struggle with when you are walking a patient down the hall and something happens and you assist them to the floor. To me, that's a rapid assessment, a quick decision, and you plan to send them on the floor or put them on the floor, but they don't see it that way, unfortunately. It's still a fall. It's an assisted fall. A fall can result in fractures, lacerations, internal bleeding. It can lead to increased healthcare utilization. And research shows, this is the important part, that up to 1/3 of the falls that do happen could have been prevented. So those are the ones that we want to focus on. As of 2008, CMS does not reimburse hospitals for certain types of traumatic injuries that occur while a patient is in the hospital, and many of these can occur after a fall. Everybody kind of teases me at the hospital because I'm really passionate about falls now. So if you ever want to get any of your employees or your coworkers engaged in something, have them do research on it, and then all of a sudden they care a lot more about whatever that subject is. Regardless of how falls are defined, they occur far too frequently, and they have serious physical and psychological consequences to patients. So there's definitely an identified desire and a need to decrease fall rates in many organizations, if not all, including ours. And being that nurses and nurse assistants are the ones at the bedside and providing direct patient care, they have the best chance at preventing patient falls. And the research actually shows that many of the falls happen around toileting, and this is often delegated to our UAPs. So this is where I got my idea. I did a review of the literature, and I looked in CINAHL, Medline, Cochrane Systematic Review, and Health Source Nursing in Academic Edition. Some of the keywords that I used were patient falls, inpatient, and fall prevention. And I tried looking at nurse assistant, nurse aide, but then that's when I discovered to use unlicensed assistive personnel, because that was a broader term that more people use. And as far as the gap, I really couldn't find any research. And when I started this was last fall, I believe. And at that time, I could not find any research specifically geared toward the UAP. It was all towards the RN, which makes sense in a magnet world and in a C&E world, because who is our target audience? It's the RN, it's not the unlicensed assistive personnel. But a common theme in the literature was that falls are associated with the lack of adequate routine patient care related to ambulation and toileting and response time to call-outs, which are all things that UAPs can do. And being that falls are often happen around toileting, I wanted to explore this area a little more in depth. And I don't know about where all of you work, but our nurses, I've worked at UMC for 20 years, and over the past 20 years, I have seen what the nurses are required to do at the bedside just like double and then triple, and get what things that were supposed to make things safer and easier have made it almost more cumbersome and more difficult. And so anything that we can delegate, we should delegate. And so this was one area I was hoping and thinking that maybe we could delegate. So my PICO question was, does the implementation of specialized fall prevention program for nursing assistants, or UAPs, decrease the number of falls and the number of fall-related injuries in patients 55 years or older as compared to our standardized fall prevention training? And I don't know if I mentioned this, but this was my first research project, and I learned a lot, and it might be my last. Oh, I'm just kidding. No, it was actually really interesting, but it was a little traumatizing at times and overwhelming. But after having done it, I'm like, oh wait, next time I will have already known all of these things. So, and one of those things would be like how important your PICO question is. Even things like, I used nursing assistants in my PICO question, and I could have used unlicensed assistive personnel. So. For my research procedure, my study analyzed fall data routinely collected at UMC pre and post intervention, because I wanted to look at the effectiveness of the training course. I collected demographic data from the participants, And then I looked at the fall rates for 3 months before the intervention and 3 months post-intervention. Ideally, I would have had a floor that we didn't do the intervention on and a floor that we did. But the way we staff at our hospital is we use a resource pool. And so our resource pool is largely made up of nurse assistants or UAPs, and they go to all of the floors. So you couldn't really have a control unit where, to look at it that way. So we just looked pre and post. The research was approved through LCU's IRB and then through Tech's IRB. And so another lesson learned was I didn't have a good grasp on how long it takes to go through those processes, especially to go through 2 processes, because we had to complete one before we could start the other. Otherwise, we would have been trying to make changes at the same time. But anyway, this was the demographic form that I used to collect data on the UAPs. I obtained consent at the beginning of the class, and not everyone participated, but the majority of them did participate. And we did have it as a mandatory class, but it was not required that they participate in the research. I collected demographic data, I looked at educational experience, years of experience, previous training on falls, and I wanted to look at how these had effects on our fall rates. And then we analyzed the data using SPSS. The sample size that I asked for was 80 nurse assistants, and some lessons learned the hard way was to ask for more participants than you think you're going to get. It was interesting because when I asked how many nurse aides we had in the hospital, I had a report that told me we had 60. So I was like, there's no way I'll be able to get 80. Well, I had 110 people come through the class. So they were coming out of the woodworks apparently to come to my falls class. So if I ever do this again, I'll ask for more than I think I could possibly get. And another lesson that I learned was to make sure whenever I collect the survey that all of the pieces were filled out completely. I almost felt like I shouldn't be looking at their things because I wanted it to be anonymous, but then when I got them back, I saw that there were some blank spots. So I would have made it clearer to make sure that everybody filled every box out. When we looked at the demographic data of the actual UAPs, the majority of our UAPs were between the ages of 18 and 35. And we did have a few that were older, between 56 and 65, and those were our nurse aides who've been there, 10, 20 years. And so there was a little bit in the middle there, but the majority of them were between 18 and 35. We had a lot of nursing students that actually came through the class and who are working as nurse aides while they're going to nursing school. And so it was interesting to me because, and a good thing I think, because these nurses will probably stay with us, and so they'll have had this extensive fall training and hopefully have a keen interest in it. So that will be a good investment for the future. The majority, not surprising, were female. 80% were female and 17% were male, and 2 declined to answer, so I'm not real sure what they were, but either or, I'm assuming. As far as previous training, about 60% of them said that they had some sort of previous training, and we did have an online nursing orientation in Moodle that does talk about falls a little bit, but that was about the extent of that. As far as years of experience, our UAPs ranged from less than a year to over 43 years of experience, but 27% of the group had at least a year's experience, and about 16% were at 2 years, and then we had kind of here and there between there, but then we had 6% that had about 20 years experience. So I think those were our older ones that have worked there quite a while. So what I did was I taught a 4-hour class. Get all these up here. And these were the objectives of the class. The course was developed around the Center for Improvement in Healthcare Quality Training course for fall prevention strategies. The nurse assistants participated in this 4-hour class, and we had groups of 10 or less, and the class contained a 1-hour didactic portion. And in that 1 hour, I focused heavily on building the nurse assistants up and their self-efficacy, and encouraged them and talked about what a huge difference they could make in patient safety. And I talked to them about how I used to be a nurse aide, and then I was a nurse assistant, and that whenever I was a nurse aide, that I felt like I had a lot more time with the families and developed a closer relationship with them, because the nurses were so busy giving meds and whatever that sometimes the patients trusted me a little bit more. And so I really tried to focus on that and make them feel like they could make a real difference. So after the class, after the didactic portion, I would give them report on 2 patients. And then we would leave the classroom setting and go up to 2 patient rooms. And I had 2 standardized patients that I used. And one of my patients is over here, Kim. She was the diva. She was the diva, and she did the same scenario for each one. And when the nurses or when the UAPs would come in the room, the bed would be all the way up as high as it could go. There would be trash on the floor, including her makeup wipes that were wet, and she was dropping off on the side of the bed. She hid the bedside commode. She didn't want to look at that, and she didn't want to wear the yellow gown because it just wasn't a good color for her, and the socks weren't comfortable. So she was all tangled up in her cords, and she had just taken a lot of pain meds. And so they got all of this in their history or their report, and then she would have a similar conversation with them, based on how they were doing as they rounded. And then our second patient was a nonverbal patient, and they were told that the patient was nonverbal, but they would follow commands if you talked to them. And they had been tied up because they were pulling at their IV and trying to pull it out. And this patient, when they would have all 4 side rails up, the bed would be high, and they knew that whenever the nurse aide knocked on the door, they would be crawling out of bed, like going over the side rails. And so we wanted the nurse aides to skip hand washing, but it was interesting because a lot of them would sit there and look at them going over the bed and wash their hands because they were going to make sure they got that right. And so that we wanted them to run to the rescue and get them settled and then come back and wash their hands. But we had props on the floor, and we had no family at the bedside. The door was shut. The room was far away from the nurse's station. So these were all things they had to kind of recognize and deal with. And so then we would record them as they did their purposeful rounding, and then they would come out of the room with their iPad, and they would meet with me or another educator who I had trained, and we would debrief with them, go over how they did and what they could have done different, and then they would go back and do the other patient. And out of 110 people, I think that maybe only 2 of them remembered all of the interventions. It was pretty interesting. The things that were forgotten the most, I think, are what we see when we look at our post-fall huddle forms. The bed alarms didn't get put back on. The side rails were up. For whatever reason, with all 4 side rails up, they would not recognize to put them down. And then maybe not necessarily put the brake on the bed, and none of them knew what to do with the restraint. The patient only had 1 restraint on. They had gotten rid of the other one, and it was untied, and they weren't real sure what to do with it. So in the class, definitely we used it as a needs assessment for our annual comp fair this year. So this is the debriefing tool that we used, and it just went through every little step that they needed to do. And it was interesting because when they would come out of the second room, they could already tell you on the way to the debriefing, oh, I forgot to do this and I forgot to do that. And they were like getting excited about it. It was kind of like a game at that point. We actually had some pretty smooth talking guys that came through the class, because Kim was really impressed because the story was she didn't like the yellow gown because it didn't look good on her. And this one UAP, I think he told her, oh, but I think that color just makes your eyes pop or something. And we were like, oh wow, he's good. So we had a few that were real charmers and that could really talk to the diva and make her comply. And we were like, oh, we need you on this floor and this floor for sure. But and then after the class, I wrote them a handwritten thank you note, and I gave them these little badge cards that had all of the interventions, so that they could have reminders whenever they were doing their rounding. But the whole class, I really focused on, there was nothing negative. If they forgot, I told them, you're not gonna pass it, you're not gonna fail, all you have to do is try. This is just practice. And so I think going into it, they were a little nervous, but by the end of the class, they were having a good time, and they really got into it, a lot of them did. And they really wanted to do good. As far as the results go, we used a chi-square to test the proportional difference in falls with the significance defined as an alpha level of 0.05, and we used a multiple linear regression model. We're still looking at the data in more detail, and we'll continue, especially once we get the cost. That'll make a big difference. So the 2 floors that we looked at were 4 West and 5 East, and we looked at the second quarter, and on 4 West they had 9 total falls in the second quarter, and then in the fourth quarter they had 6. And then as far as falls with injury for that group, they didn't have any injuries in the second quarter, and they only had 1 with minor injuries. But so their falls with injury rate did go up a little bit on 4 West. On 5 East, they went from 8 falls to 3, and their injury rate actually did go down. This is the 5 East pre-intervention and then post-fall incident rates per 1,000 patient days. And I mean, you can see a general trend. We kind of joked that the yellow part was where the intervention happened, and we were like, what happened? And they're like, well, the nurse aides were in your class the whole time, so there was nobody to take care of the patients. But I don't know if that's true or not, but possibly. And then this was 4 West, and you can definitely see a decline there. And then this was we just looked at the house-wide fall incident rate overall, just to kind of see where we were at, because like I said, the resource pool nurse aides came to the class and they did go to all of the floors. Here we're looking at the overall fall rate and then the fall rate with injuries. And this is, we did the training in June and July, and then and some into August. As far as the research goes, I stopped collecting participants in July, but I am still doing the training class once a month. So I'm going to continue to watch the rates throughout the year. And then also from the class, in talking to the nurse aides, they were really appreciative of the class because they said they don't really get anything that's just specifically for them. And so we were talking about the annual comp fair and how that it's more geared towards the nurse. And so because of that, we decided this year to pull them out of the nurse comp fair, and we're having a UAP specific comp fair where we're going to talk about what effect they can have on all of the big Indian QI things, CAUTI, CLABSI, falls, and a lot of different things. So it was pretty interesting. They really enjoyed the class, and it was good, because I don't know if any of you are educators, but whenever you're teaching an audience that doesn't want to be there, it's not all that fun. But if they're actually engaged and want to participate and want to learn, it's a lot more fun. And this was our total falls with and without injury, and then right here is pre, and then intervention, and then post. When I talk about being passionate about falls, I'm not kidding. Everybody who falls now, I'm just like, no. I mean, I feel like I'm constantly going around checking the floor and making sure everything is good, and it's definitely something I'm passionate about now. During the class, I talked to I tell a bunch of stories about personal fall stories, and with my family members, and then with patients that I've had, and with myself, and I really try to get them engaged and really bought into it. The rest of these slides are what I used in the class, and so I talked to them about what was their role. The main focus obviously was on purposeful rounding, but I talked to them about patient safety. I'm just going to kind of glance through the slides, not go through the whole class with you, obviously. We talked about key aspects of a fall prevention program, and then with these, I would click on this little thing right here, and it would go to the more detailed things. I'm not going to go into that part with y'all. I'll just go through the basic topics of what we talked about. We talked about fall risk factors, what things might put a patient more at risk, and then we talked about family and patient communication. This was actually something I spent a lot of time on, because I talked to them about how when they are rounding, how to talk to the patient and say, tell them the reason why you were doing things, and about how much you cared about them and how much you did not want them to fall, and how to even talk to them about, like, when you're in the room, instead of saying, do you need to go to the bathroom, as you're like backing out the door, oh, see, don't fall. And then, you know, versus while I'm in here, may I please get you up? This would be a good time for me. Is this a good time for you to go to the bathroom? And then make sure they have their call light, and that just tell them I'm going to be back within the hour. So if you need me before then, make sure to call me because I don't want you to fall. And just over and over again, and talk to the family and talk to the patient and just kind of work on that. And they got pretty good at it. And I think, like, especially the first time they would do the patient rounding, it was a little awkward, and then the second time they would get it down. I talked to him about how to talk to the nurses, because they would say that, you know, sometimes the patient would be on fall precautions and they didn't even know it, or they that maybe the patient was on fall precautions but the yellow sign wasn't on the door, or this and that. And I'm like, well, go do it. Y'all can go do it. There's nothing saying that you can't go put the sign on the door, the band on them, the gown on them. Y'all can definitely do that. Like I said, we spend a lot of time on how to round and how to do purposeful rounding, because that is the most effective way to prevent falls. I talked to them about what is on a risk assessment and what the RN can do, and then you know, not that they would chart that. I was like, however, you are human beings, and you're in the room with the patient, and you might be the only one who gets the patient up. And sometimes as a nurse, we do our risk assessment, but we may not be the one getting them up, and they may be really dizzy or have a bad knee that they are wobbly. So if you find that a patient is at risk, you think they could fall and they're not on fall precautions, just go have a conversation with your nurse. We talked about universal fall precautions, and we talked about what to do if your patient does fall, and then we just had a summary. And then these were my references. And then, like I said, when I would click on those little light bulbs, the more detailed things would pop up. But overall, it was a good experience. And another lesson learned, whenever you're taking a group of people from a classroom setting to an inpatient unit, I learned to take them all at once, because I did have one poor fella not make it he got lost, and then I wasn't using my phone because I was teaching, and so he missed the practice on the rounding. So, but anyway, that's about it. Do y'all have any questions?
Dr. Stinnett?
Oh, you want to go next?
Yeah.
I thought we were going to do maybe questions.
Well, you want to do your invited response and then we'll do questions? Or are you going to do your response based on our questions?
So this is my first invited response, so I don't do what I'm supposed to, y'all tell me.
Well, this is my first research project, so if I didn't do what I was supposed to, you tell me.
And when pediatrics falls, they just get up and keep going. So we don't worry too much about falls, right?
Well, it's funny you would say that. One of the stories I told in the class, which is actually true and a little embarrassing, but I went to lunch and I reported off to my nurse friends, and I was like, okay, watch this, kiddo over here. He's in a crib, side rails up, everything's good. I'm walking back with my cafeteria food, and I look out of the corner of my eye, and there's my patient swinging from the bed. Blood pressure cuff, good Velcro. They didn't hit the floor. That's not a fall. That's a bungee jump.
That's right. So I had to educate myself on falls. So I went and got some statistics. I appreciated yours, Hillary, but these really kind of hit home for me. 25% of Americans 65 or older fall every year. This is outside the hospital. This is not in the hospital, this is what was scary to me. Every 11 seconds in the United States, an older adult is treated in the emergency room for a fall. This is outside the hospital, okay? Every 19 minutes, an older adult dies from a fall. This is from the National Council on Aging. In 2013, the estimated cost was $34 billion for falls in the United States. They project that cost in 2020 to be $67.7 billion. Joint Commission says that it increases length of stay by 6.3 days. I think you probably had something from the joint there. And they have an average cost of $14,000.56 per incident in the hospital in costs. So You talked about never events. The wonderful 2008 Medicare comes out and says this is a never event. And I just told you 25% of us have over 65 fall outside the hospital. So how can it be a never event, right? So anyway, I just have a problem with that. But, so when they did that in 2008, they started looking at the numbers for central line associated blood infections decreased by 11%. Dollars talk, right? CAUTIs decreased by 10%. Falls didn't decrease. There was no significant decrease in falls. So we're not doing something right. I don't know what it is.
It's that gravity thing.
And then I found this one article. So then you start talking about hospitalized patients and the incidence of delirium on top of the fact that they're over 65 and 25% are going to fall anyway outside of the hospital. And we have them in an unfamiliar environment, and then they get delirious. And the incidence of delirium can go as high as 82% in the hospital, depending on if it's an intensive care unit. I'm like, how do we not have people fall? So this is a very appropriate topic, and I think the way you approached it was great, going to the non-licensed people, because they're the ones that are in the room. You said that. I thought that was great. I also loved, and I just have to point this out, you said it was a never event, and on slide 3 you said, I don't think we can prevent all falls, which is exactly right. So we're in a quandary here with Medicare, and what do we do to fix that? And I think you do what you can do. And so I heard her say several times, I learned this lesson. So my next question is, what's your next project on falls? It's the QI coming out of you.
Yeah, well, actually, we're continuing the class.
That's right, because it was successful, correct?
We're changing nursing orientation to include the purposeful rounding with the fall prevention for the new nurses as well.
So have you got any ideas from your aides and techs about what they thought would make it better?
They had actually some really good input, because I actually got them to be involved on our fall committee as well. They brought up some really good points. One of them talked about how if a patient is at high risk for falls, whenever we take them to CT or MRI or wherever, don't even get them out of the bed, just take them in the bed, because that's how many ever transfers less, that you're doing. And then one of them had a good point, because there's some question on should you keep the bedside commode at the bedside or should you not? Because the one lady was like, well, I know this one lady who comes in all the time, and if the bedside commode's at her bedside, she gets up by herself. But if we put it away and hide it from her, then she has to call us. I was like, oh. So you kind of just have to decide with each person individually.
And then you get those stubborn men like me that don't want any help.
Yes. And that's
doesn't matter where the bedside commode is.
Yeah, and who wants an audience when they're going to the bathroom? Honestly, I don't.
I just felt like I didn't know anything about falls, and I thought, well, this is really good. You didn't get it to 0, but you dropped it.
No, yeah.
And your slides I thought were really good. You're showing a trend down. How do you keep it there is the next question, because sustainability with QI is the huge thing.
Well, we're adding it to the Nurse Aid Comp Fair.
Exactly.
We just talked about that
today. So you're not
today.
letting it go. That's my
No.
point. Don't let it go. You got to take the next step, and how do we sustain what we're at? I just thought it was great. Shocking numbers I saw. That's all I have. Are falls a problem? Everybody, inpatient workers, falls a problem where you're at? It's universal. So how do we fix that problem? We figure out that it's a problem, and we come up with a way to fix it. We trial it, and we see what works, and we just keep going. I'm sorry, QI again. QI, it's all QI.
I told y'all it was his passion.
Yeah.
Do we have any other questions? Yes,
I just have a comment, and when you were talking about how involving the unlicensed personnel, we just started with nurses' aides, in January I think it was, working on education just for the unlicensed people. And so those that work where I work might want to talk with you further about, seeing your tool that you're using, and maybe develop something along the lines of what you've done for more interventions for many of our people that are the ones usually assisting folks to the bathroom. So I'm glad that you brought that up, because that's one thing that, and it's amazing because they have wonderful ideas. know, and so kudos to you for doing that.
Yeah, they were a really engaged group, and they did have good ideas. And that's the thing for me. Anytime I shouldn't be the one deciding what we're gonna do about falls. I don't take care of patients anymore, and so anything that we're doing, I'm like, why are you asking me? Let's go ask the people who are in the room, for sure. I was gonna show you this if we have time.
Dr. Stinnett, while she's.
I have a couple other questions while you were finding it, if that's okay.
Mm-hmm.
How did you choose the 2 units that you used for your study?
Just tried to pick ones that had a lot of falls before. They were having
Were they
issues with
highest
falls.
grade falls?
Mhm.
What type of units were they? Med-surg or?
Adult med-surg-ish combination. The 5 East it's a step-down ICU, but it's still, it's like a cardiac type floor,
Yeah,
step-down. And then 4 West, was it 4 West? Or 4, I get West and East confused, is oncology.
There you go.
The one thing I noticed that you did that you didn't really measure was I felt like you empowered them and you motivated them. And the one specific thing I noticed was their badge now says Certified Fall Specialist.
Yeah, I know. I'm like,
And I wonder what the
them.
impact that had on just building their self-esteem and empowerment for a non-licensed person.
Because they don't really we don't do anything special education. We don't do any specialized classes for them at all. But like even in my healthcare resource class, we talk about having nurses there's a shortage of nurses, but how awesome would it be if we could have more aides that if each aide only had 5 patients, then they could spend 10 minutes in their room each hour and then have 10 minutes to do, so that's 10 minutes of sitter time. Don't fall. Yes. We love you, don't fall.
Brandon, you have another question? You had your hand up again.
I have another one.
Yes, I thought you did. I knew you.
You showed communication on one of your slides.
Mhm.
So what did you do to address that communication gap between your aides and your license?
I told them when I was talking to them about if you see a patient who might be at risk for falls, or if you see equipment that's in the room that doesn't need to be there anymore, to have a conversation with your nurse, see if we can get it out, or see, if they are finally putting them on fall precautions. But then also just talking to the patients and the families. So it's like, I'm gonna put your bed all the way down because I don't want you to fall if you get up, and I'm gonna put your side rails down, and blah blah blah. Just kind of gave them some scripting to use while they were doing their rounding.
Just a comment, if it's
Mhm.
okay.
Yes, please.
Just a comment, I'm so proud of the work that Hillary did and that all of you are doing, because you can see the potential impact of what you're doing in real time. Really, really making a difference in people's lives and saving your organization's money, and you're reducing length of stay. And this is in our hands. We have the ability to do this. But a question or comment I have for the audience, we spend a lot of time trying to differentiate quality improvement, EBP, and research. And Hillary started this in Dr. Ford in my research class. And so because of that, she was sort of lovingly forced to turn it into a quote research project. But in actuality, this project, there are elements that could be viewed that way. But in actuality, this is a perfect example of a quality improvement for evidence-based practice project. It's not a true research project, although we wanted her to learn some of the aspects of research. This is clearly a quality improvement project. So while we're still going to play with the data and do some things with it, these sorts of questions, it's irrelevant whether or not it's statistically significant. Who cares? She reduced the fall rate. That's what matters. That's what matters. And so a run chart is a much better way of depicting what she's learned and what matters here, not a statistically significant, that we can do that. We might have to do some little things like that in terms of publication, but it's so important for us to see that the bulwark of our work really falls into quality improvement for EBP. It falls there. And it's not to say that a good old juicy research question might come out of it and we maybe need to ask that, but more often than not, it's going to fit right here. And yet all that you're learning can be applied in various ways. So she just did a brilliant job with this.
Well, I wanted to show you all this video because we're pretty proud of it, but I would show it at the class. Oh, I hope it'll play. Is there sound? Okay. Call if you want to come over here and see it. No, I but no, we made it in here.
Look at my scar, I'm colored black and blue. I'm pretty dizzy too. That's why I'm wearing yellow. I had to go, I didn't call for you. And took this. So now I'm wearing yellow. And ask me if I'm okay. Just ask me if I'm okay.
He had tattoo stickers on all his work.
He's a good actor.
I called him Joe.
Oh no, this is the best part.
Wasn't quite so strong. And turned to walk along. Now we're both to you. You can't prevent my fall. Just know the protocol. Look for my yellow. Yellow cow. They need a risk of fall. In the bathroom, outside or in the hall. If you see me, make sure you offer your help. You've got to offer your help.
I tease everybody because I'm like, he really wasn't that short, but every woman that was in this video is like 5'11" or taller.
Colored black and blue. I'm pretty dizzy too.
Yeah. Anyway, so I would show that at the beginning of the class to kind of get them laughing for sure.
Elaine, you had another
Well, I
question?
just want to say that
Or comment?
outside the hospital, I have 2 elderly parents, and they both have canes, walkers, but do you think that when we go out, that they will take them?
No.
And they hold on to each other, they're both very unsteady, and they just make me a nervous wreck. You know, and it's not like they don't have AIDS.
Yeah.
And
Free will. It's that free will and gravity thing. I'm telling you. That's the
I
that's
wish
the problem.
we could figure out how to help these.
Yeah.
how to- you know?
Yeah. Well,
Anyway,
one of the
it's
stories.
very frustrating when you know that it can be prevented, and they're so vain. I suppose they don't want to be seen with these AIDS.
Well, one of the stories I would tell in the class, and it's a true story, is my grandfather fell in his home, and he was in his closet for 3 days before anybody found him. And he got admitted to the hospital, but if you would ask him if he'd ever fallen, he would say no. So I was like, you can't always believe, you know, what everybody says. You actually need to assess them whenever they get up to walk and see how they're doing. Because, I mean, she wouldn't admit. I mean, she wouldn't admit it.
But we know she did.
Yeah.
Any other questions from the audience?
I think it's funny because I was admitted actually last week in the hospital, and she came to see me, and I'm pretty sure had I fallen while, and she told me, you better not fall while you're here.
Yeah, that's threatening. It's another intervention.
Yeah, I think she might have fired me.
Yeah. I went in there and I was like, was your bed down? Is your side rails? How are we doing? Are you at fall risk right now?
But I'm youngish. I'm almost 40. And I was by myself a couple of times, and I didn't want to call for help because I'm a nurse and I know how busy nurses are. And I got myself up to the bathroom, and there were a couple of times that I was a little woozy. I'm sorry, Hillary, please.
What? No.
Because it's a total pride thing.
Yeah.
Even young people who you wouldn't even suspect are at fall risk really are in denial and are.
That's funny, because last time I was in the hospital, the night nurse kept leaving the light on, and I can't sleep with the light, so I climbed in my bed to turn off the light from my bed and pull out my own IV, and I thought I could have fallen out there, so I can see it, Kim. See, us. Any other questions or comments from the group? Stacy, I hear you have door prizes. Let's bring it on.